Hello, and welcome to a very special podcast that is part of a series I'm leading on diversity and inclusivity with CME Outfitters. Today's CMEO podcast is entitled Parameters of Pain Care, Mitigating Racial Disparities in Pain Care. I'm Dr. Monica Peak, a professor of medicine at the University of Chicago. I'd now like to welcome Dr. Carmen Renee Green, professor of anesthesia and obstetric and gynecology at the University of Michigan. Dr. Green, I am so honored to have you joining us today and really excited about the discussion.
Well, thank you. I'm thrilled to be here. This is a very important topic. It's a very timely topic. So I'm looking forward to our conversation.
Me too. You're really an inspiration. And can you tell us what inspires you in your advocacy work in pain care?
Well, it's really been about the unequal burdens and the unheard voices of people who live with pain, who live with healthcare disparities, who don't get the quality of care that they deserve. It's hearing their stories, it's having the honor to take care of them, to be their healthcare partner. And so it's that has spawned my research. It is that has spawned my advocacy.
Thank you. I think for a lot of us clinicians, it is that personal experience with patients, with people in our community that motivates us to want to do this work in both our research and our advocacy. So thank you so much for being part of the effort to try and mitigate disparities. Let me begin with our first learning objective today, which is to identify factors contributing to disparities in pain management. Dr. Green, we know that African Americans are systemically undertreated for pain, regardless of socioeconomic status and access to care. What is the link between clinical bias and pain care disparities?
Well, great question. Fundamentally, we know that there are significant biases, particularly racial, some gender, and also some socioeconomic biases that contribute to people receiving lesser quality pain care. We know that overall the pain intensity of African American as well as Native American people has been underestimated consistently. We are more likely to recognize pain in white people as opposed to Black people, and that most of the studies have been done based on Black-white differences. That doesn't account for some of the other emerging literature that focuses on other patients and people of color, such as our Arab American population. We also assume criminality. We live in a world where our biases and our perceptions are real until tested. And we assume that there's criminality amongst Black people without evidence often. We've certainly seen that over and over again, that socioeconomic status is protective for Caucasians, whereas not protective as it relates to people of color, particularly African Americans. We also know that Black and Hispanic, Latinx women are more likely to experience or thought to experience less pain during labor. And that probably is also a historical remnant, which we don't have time to discuss today. We also know that Black women are underdiagnosed and undertreated for endometriosis, often due to the incorrect belief that this condition is more common in white women, and therefore we shouldn't be, we're slow to assess it in Black women. And we've also had studies where, even though we have, there are studies that suggest that even for long bone fractures, Black people receive lesser quality care, even when you have diagnostic evidence of it, that even if you're assessed for pain, that people, and it's deemed that you do have pain, that people still have lesser access to sufficient prescription analgesics, opioid analgesics in particular, than in white neighborhoods. And that we also know from our studies that show that socioeconomic status is not protective for Black and brown people, where it is protective as it relates to Caucasians.
It makes me think a lot. I think it's been part of the national conversation recently in how we have been treating the opioid epidemic currently compared to the opioid crisis several decades ago, now that it is affecting middle America, rural America, white America, and we're leaning in with a public health approach rather than a war on drugs approach, a criminality approach. And so I think this speaks to a lot of the things you had just mentioned, and how we perceive pain and pain treatments based on who the population is. You have, Dr. Green, researched the burden of pain extensively. What are some of the implications of this disparate pain care?
Yeah. So let me begin. And all of this begins with hearing the patient's story. And I've had the honor of taking care of people who've not received high quality pain care. And that pain care disparity exists begins actually in the primary care arena. So I thank those patients for their stories. But we know that these disparities exist across all the medical specialties and in all settings: surgery, cancer, emergency care, and also in the gynecologic and obstetric population. Some of the studies by my colleague and friend Knox Todd, which show that Black patients are less likely to receive analgesia for fractures. That's the study I mentioned earlier.
Mhm.
In the emergency room, even though you can sort of look at the fracture. We know that this is also true for our children, which is extremely disappointing. We also recognize that there's a distinct link between the psychosocial stress and the depression and the perceived outcomes as it relates to other types of pain, osteoarthritis, and mental health. If you look at the psychiatric literature, minority people, people of color are often given more diagnosis that suggests a greater impairment. Undertreating pain contributes to a number of different problems. Is it consistent in regards to how we think about the healthcare system and who is it there for? So contributing to medical mistrust, the overuse of over-the-counter medications, and the sequelae that can occur because of overusing something such as an anti-inflammatory or acetaminophen. We also recognize that they are later to come to have treatments such as replacement of the hip or the knee, and that leads to increasing disability and decreases the quality of life, and potentially beyond the morbidity may also contribute to mortality because you're taking care of people at a further state. And certainly when you think about mothers and grandmothers and grandparents not being able to participate in activities with their children, those are things that are particularly important. Now, when you can think about musculoskeletal pain, Black people and Latin people have access to fewer orthopedic procedures, like I mentioned before. These delayed access to treatment progresses disease. And so then it's not surprising that you offer a procedure and it doesn't provide people the same type of benefit that it provides a Caucasian people. So those are significant implications. So our studies and most studies have really talked about how race influences pain management and quality of life, and that this perceived discrimination can contribute to hopelessness, further depression, and actually feed back into some of the negative sequelae associated with pain, such as sleep disturbance, depression, anxiety, and certainly mistrust. And those are things that we can do a whole lot better with.
The fact that biases are even programmed into the algorithms that we use to monitor prescription drug use is really remarkable. And we're learning more and more about how structural racism is sort of baked into some of these algorithms in a wide variety of conditions and specialties. What can you tell us about these scoring systems and how they can worsen pain care disparities?
Well, that's a great question. I bring forth this story of a patient who said, Dr. Green, his pain was being really well treated. And then she says, I can't get these prescriptions anywhere. And that speaks to, the bias. And pharmacists are asked to do a certain type of job to make certain these prescriptions are legitimate. But we ask those questions more of people of color than we do of the Caucasian population. Minority people may be viewed as drug seeking, and they may be flagged as they come into the pharmacy or into the primary care or even the specialty care arena as doctor shopping or drug shopping. You see that it's really clearly emphasized in some of the ways that our patients with sickle cell are treated, and that's the sine qua non in many ways for the undertreatment of pain, because it particularly occurs in a population that is um, of color. We also know that people of color don't trust, and so sometimes they go further for to seek high quality care, and when they do that, then they're deemed as potentially a bad patient because why didn't you get this taken care of in your community? And that really comes to, so there's often disconnect between patients of color and the healthcare providers who are taking care of it, who predominantly are not people of color. So the algorithms are not transparent, and failure to include sort of these social determinants of health. And let's also be clear that the percentage of physicians who are of color is still much less than their representation. So again, this shows how representation matters in taking care of people. The drug monitoring systems, these data, doctors have the fear of that their license, they're being monitored or their license is in jeopardy, particularly as it relates to people of color. And that's a socialization process.
Thank you. We've talked about this critically important problem of inequities in pain care and their impact. Let's now turn our attention to the next learning objective, which is to integrate strategies to provide equitable pain management for all patients. So that's learning objective 2. Dr. Green, in your vast experience, what are some of the ways in which we can provide equitable pain care, and which models have worked in the past?
Well, this is a complicated story. It's interesting how, we have criminalized pain treatment for people of color and medicalized it for Caucasian population. So let's begin there. So this is actually a large, not just a healthcare issue, but a societal issue. Our discrimination, our biases and stereotypes of who is deserving of high quality pain care, when actually our oaths suggest something different, regardless of what oath you've taken as a healthcare provider. So these biases, implicit, unconscious, and conscious biases, pop up throughout medicine. Further, these biases are also incorporated within the education of the physician. And so, if you look at some of the great textbooks, the Benica, you look at even how the very origins of taking care of patients in this country, and how we thought that Black people, the enslaved person, could not really appreciate pain. And that's those types of stereotypes, those types of misconceptions carry out today. So there's a lot of data, and some of it's promising, that by addressing some of our biases, and to the extent that we can educate people about these disparities, and the structural violence that's associated with it, we can actually address some of these disparities in care. In fact, when I was working in the United States Senate, one of the things that got people to sign on to the National Pain Care Policy Act was the whole conversation that certain populations were not receiving high quality pain care based upon their race. So when we take these perspectives into our mindset and think about how we take care of patients, we saw a decrease in bias. And the physicians and the healthcare professionals developed more empathy and trust for the patient. Now, that may take patients a longer time to get to that point. People often say, well, it's about Tuskegee. Well, there's a lot of things that happen beyond Tuskegee. And then I think of the equity-oriented care framework, where we understand the social determinants of health, or attempt to do so. And we understand the complexities of the patient's experience, particularly as it relates to pain, are important. These traumas that some of our patients experience are very real. And all it takes is one time in which patients are not trusted or believe that it contributes to a whole cascade of mistrust and lessens the quality of care. So really thinking about patient trust, and that trust is really earned, and it's a two-way street, but the healthcare professional has to do more of the work. And that that people, regardless of who they are or their status in life, whether they're a returning citizen or whether they are Black or brown or lower socioeconomic status, that they should have access to high quality pain care. In the way that we actually even sometimes, forgive me for the analogy, but one of the people had a animal, a pet, we actually sometimes give better quality pain care for our animals than we do for our human beings.
So I'm saying that's a remarkable statement, and one which I will never forget. I think that that's going to stand out in the minds of all clinicians who are listening to your talk right now.
Thank you. So but it's important, and so and if I were to go further in regards to that point, one of the studies that we did showed that, if healthcare professionals had somebody in their family close to them that experienced pain, that actually improved the quality of pain care they gave to patients. And I would say our patients should not be dependent upon someone's mother or father having pain and having it adequately treated for them to have it adequate. Nobody should live with pain if there's something we can do about it. Now, yeah, so, let's talk about the individual patient. There's the injury, there's the trauma, and then there's all these characteristics which we talked about, the social determinants of health and how they influence a person's perception of pain. All you have to do is go to the OB suite, and you see lots of different women all going through a similar process, and you see different variability not different. You see variability in the responses to that process.
Mm-hmm.
The other thing I would say is, the provider characteristics. The assumptions that we make about who's deserving and who's not deserving. I tell my house officers, the person who is in prison and who comes for care, are they not deserving of care? Well, it's our job, as in the oath that we took, is to make certain that people get the best quality of care. And then how we think about our clinical judgment, our knowledge as it relates to pain. And then, most medical schools still are undereducating people as it relates to pain, its impact, as well as how to adequately treat it. And then all these things sort of influence how patients receive care and what we decide to administer. Who gets a referral? We showed in previous studies that essentially women were less likely to have a referral for their pain care when they presented, although they presented for the same problem as men. And how does that influence the care of Black and brown women? Some of this we don't know, but we can guess what the answer is.
Mm-hmm.
So there's several strategies that I would think about as far as removing the bias in pain care. Education, education, education. And what's not on this slide is actually advocacy, advocacy, advocacy. We are, as healthcare professionals, to be the patient's advocate, not the advocate for administration, not the advocate for, we're to be the advocate for the patient. And so we need to educate healthcare professionals and dispel any myths and misinformation about the conversation as it relates to race and pain. We need to think about this from a cultural humility standpoint. People talk about cultural competence. I would say that any point in time we can all be struggle with our cultural competence. What I think we need is actually cultural humility, a place and a space in which we can be humble in what we don't know. And then I think really accounting for, asking for our physicians and our clinicians to be accountable for some of the decisions that they make, as well as the institutional accountability for pain assessment and treatment, and the role that our failure to educate, the failure to advocate may contribute to inequity. I've been a strong proponent of how we need to think about collecting data on patients' age, race, gender, the social determinants of health, and including their insurance status. More and more, I as a pain care specialist, there are things that we would advocate for our patients, but their insurance will not allow them to, to have those particular treatments. And then I would also say we also need more research that shows that the treatments that we're providing do or do not work, and in whom. Then I think, discrimination. I think, in many respects, the incidents about George Floyd has brought the whole conversation about discrimination, racism to the forefront, and it's actually the silence, the challenge, the lack of ability to explain what we're seeing in front of our very eyes. All those things come into play, and what we see and who we hear, and that's why I talk about the unequal burdens and unheard voices. I think the clinical guidelines and protocols that we also need to make sure that they work for not just Caucasian, not just for men, but for all people. And if they don't work, how do we think about individualizing? So it's a little bit of like we talk about one size fits all, and one size may not fit all. And we need to think about this. So most studies that have been done in this country have not incorporated a representative number of racial ethnic minorities. And we need to do that. And we need to think about these things from looking at their social determinants of health framework.
So this is a wonderful conversation. So you've talked about how the education and training programs can help mitigate bias and clinician interpersonal racism, which is amazing. There are many interventions that have tried to do this and have quite honestly not been successful. So hat tip to your team for being able to do so. And you've also talked about some of the strategies to address structural racism. Are there additional things that you want to make sure that we've talked about as far as interpersonal and structural racism in sort of mitigating these disparities in pain care?
Yeah. Well, first of all, I think we need to build pain care, since one of the things that people fear the most is pain and not having their pain treated. And we've got a body of narratives that, I've written about. One patient said, I recognize I have to die, but if I have to die and there's not, and there's pain and there's something people can do about it, that's tough.
Mhm.
And I'm, not saying exactly what he said, but essentially that was his comment. And so, but I would say, we have people who come into the emergency room, we have people who die with pain, and there's things that we can do about it. And some of it's a fear of opioids, but there's a lot of things in the educational realm or the toolbox or the black box, black bag of the physician that we have not readily using, from psychological counseling all the way up into including nerve blocks and these medications. So it's not just a conversation about opioids, it's a broader conversation. So some of this starts in, there's a whole conversation about anti-racism. I think the jury is really very much out as to where this is, and recognizing that race is a social construct. And we're going to have a lot of hard work to do. We have some conversations that really are going to be difficult to talk about these things that have been intrinsic and basically woven through our American fabric since at least 1619. Well, that's when we think that in the United States it began. So we got to sort of think about some of the history. And then we need to think about our practice settings. What's the representation of the people who are taking care of our patients? What are the attitudes, the culture? Do we even ask the question, do you like the patient? I actually find that if you say, everybody says, oh, I like the patient. Of course I like the patient. Well, that's not necessarily true. I think it's important to recognize if you've got some biases against this particular patient. Either one by acknowledging it allows you to move forward. Or two, it says, maybe I'm not the best person to take care of this particular patient. And I think we need to own up to that. The training programs, some of the idealism that we choose for may go away in a system that is increasingly pressured where, and I'm really sensitive to some of my primary care colleagues, you can't get a full pain history in 7 minutes. You just can't. So how do we think about this in a different way? How do we get it reimbursed in a different way? What type of curriculums help such that we can get people past the whole conversation of race? These reporting systems that we currently use, should pain care, should the disparities in pain care be a quality indicator? And, and if not, then when? So those are conversations that need to be. The whole conversation as it relates to the diversity of the pipeline, whether you're talking about industry, whether you're talking about training programs, whether you're talking about the attendants, or those people who are in the community settings. We need to have, and with that being said, if we flood the programs right now with racial and ethnic minorities, we still won't be there. So how do we get beyond that? And I think what this really is those conversations, which I often think about and somewhat in black and white, having real conversations, deep conversations. And then our professional organizations certainly do not represent us well, and they actually have a history, a deep history of racism and actually sexism. And, it wasn't until recently that the AMA apologized for segregating physicians, and that's not just taking care of the patient, but segregating physicians, placing them in substandard settings. So I also think, these prescription monitoring systems, we need to think about those very carefully. We need to use them with caution. And recognize that, first, primum non nocere, first do no harm. And whether or not these systems are actually causing harm. That our war on opioids or the war on addiction should not necessarily be a war on taking care of the person who has pain and using the things that we have within our toolbox. And recognizing who put together these things, these algorithms, that they may have come with their own intrinsic biases. The conversation, just because you can't measure pain doesn't mean that people don't have pain. There are lots of other things that we can't measure easily, and that doesn't mean that they don't have a diagnosis. So until we can do better, we need to look at the whole person, and as we sort of move forward. And I think there needs to be more conversation back and forth with all members of the healthcare system, meaning healthcare team, from physician assistants to nurses to the pharmacists. And that the other thing I would also say is that we should really work hard to make certain that we monitor all patients equally in regards to who is deserving and who's getting the best outcomes and who's having side effects. So this makes me think a little bit about the cost of undertreated pain. And, there are a number of different studies now that tell us about the cost of pain, but we think there's about, more than $560 billion annually. And it actually costs us more than cardiac disease and cancer and diabetes combined.
Good Lord.
Yeah, yeah. So, and it's actually probably a bit more prevalent. So as people start living longer, they will experience more pain. For instance, you just think about shingles. 1 out of 3 people will have shingles if they live long enough. So the lack of pain management, though, is associated with increased, emergency costs, urgent care, and overall. And so one of the things that I would say is that we're not quite certain as to what the cost is when people don't have their pain treated and getting over-the-counter medications or using complementary and alternative modalities, which I'm not saying that they don't help, but there's only certain people who can utilize certain complementary and alternative techniques because of just insurance issues. And when you have to pay out of pocket, as opposed to having your prescription covered by insurance, for some people, that's just something they cannot do. So, the cost for pain is very real. And we think that these inequities, racial inequities, is basically associated with $229 billion in medical expenditures. And those are real dollars that we could be putting towards prevention and to elevating the quality of care for everyone. One of the things we don't know is just the lost productivity or, basically people who come to work and are sort of present, but not working at their full capacity. So the undertreatment of pain is a real problem. And we could actually be a much more healthy society if we were to take it really, really seriously.
Yes. My goodness, that's another take-home point that I think people will not forget. I had no idea the costs were so extraordinary. Thank you so much, Dr. Green, for all of your wisdom that you have shared with us in this hour. This brings us to our takeaway goals that each of us can play as a part of implementing our efforts to help end disparities in pain care within the United States. Our SMART goals today are: 1, identify and replicate and expand best practices to address the structural and interpersonal racism that cause disparate pain management. 2, improve awareness of and address healthcare provider biases in pain care for patients from racial minority backgrounds. 3, improve diversity and cultural humility in healthcare providers. And 4, implement pain assessment models and scoring systems that eliminate healthcare profession and algorithm biases. Please join me here at CME Outfitters for ongoing and upcoming podcasts and activities with more action steps against health disparities, including an upcoming briefcase, which is a patient case study in pain care. You can find out about all the upcoming live events and view previous ones on the D&I Hub at the link here. In particular, 2 of our recent podcasts examine diversity and inclusivity in 2 important areas: oral health and dermatology. We will be adding new content every month, and we really want to hear from you, our audience, on what you need to have so that we can make an impact on these important issues. Please remember to collect credit for today's activity by using the Apply for Credit button on your screen. Again, thank you so much, Dr. Green, for your input today, for all of your wisdom, for all of your hard work. And thank you to our audience for all of your work in providing equitable and holistic care to patients around the globe.